Oxygenation. The settings we discussed do not impact oxygenation. Respiratory rate and tidal volume equal a patient's minute ventilation. That is strictly a ventilatory setting. Now we're going to discuss oxygenation because we need to provide both for the patient. The lungs oxygenate and ventilate. The ventilator needs to do the same. We can determine our patient's oxygenation both by saturation, which is our pulse ox non-invasively, and much more reliably through an arterial blood gas. Now, when we first put a patient on a ventilator, we have two settings. We have two tools in our bag for the ventilator to manipulate oxygenation. We've got the FiO2, which is the percent of oxygen that we're actually giving. And we can go between 21 and 100. Usually when we first intubate a patient, first set a patient up, we're going to go with that 100%, or on the higher end of the FiO2 percentage. Now, the other way that we can manipulate oxygen is by PEEP, by positive end expiratory pressure. And this is an amount of pressure that stays in the lungs and keeps the airway stinted, but also increases our mean arterial pressure. So the way oxygenation happens is we've got that oxygen-rich blood flowing through the artery, hopefully making its way through the alveolar capillary membrane into the bloodstream. And when we give into the tissues, and when we give positive end expiratory pressure and we increase the mean arterial pressure, we allow for more diffusion. We allow for more of that oxygen, more of that gas to make its way through and make its way into the tissue. And this is how we treat what we refer to as refractory hypoxia. Hypoxia means decreased oxygen, and refractory means that it's not responding to standard oxygen, standard increase of FiO2. And that's when we're going to want to come in with our positive end expiratory pressure, our PEEP. But there are a few things that we need to be very cognizant of when using PEEP.